Hello, it's Karen Asardi, and I'm back to continue our three-part series on target lists, treatment plans, and the three-pronged protocol. So a couple weeks ago, we did part one, which was symptom-informed target list. If you haven't taken a look at it, maybe prior to watching this, go take a look at that on YouTube. It's also a part of our blog, because today what we're going to do is look at part two of this three-part series, which part one, like I said, was target lists, and part two is going to be treatment plans. So let's take a look at this, because again, like we said, we're doing this series because this is really like one of the most challenging parts of becoming a new EMDR therapist. And when we're looking at our treatment plan for our clients, it's important to consider four elements: pace, order, readiness, and symptom relief. So in this talk today, we're going to break down all four of those. So the first one is pace, and it's important to understand that the client is going to set the pace, right? And even though EMDR can, and oftentimes is, a very efficient therapy, right, to move client very rapidly toward symptom relief, that's not true for all of our clients. And so it's important as EMDR therapists for us to monitor the process and really consider which pace is best for my client. So from the onset of therapy, how fast or slow we go is largely determined by our client's ability to tolerate the history taking process. Are they able to stay within the window of tolerance? They can show emotion, but are they able to stay within that window of tolerance during history taking and not go into hyperarousal or hypoarousal? And are they able to engage in effectively containment exercises, much like we teach the container, or self-regulation, such like the calm place or breathing, and affect tolerance practices, that they can tolerate emotions when they come up, positive or negative, without getting flooded or overwhelmed in hypoarousal or shut down in, overwhelmed in hyperarousal or shut down in hypoarousal. And because each situation and each client is different, we should only go as fast or slow as is indicated by what we learn at each step. So we're consistently going through this assessment process. So we're going to, from the very moment I meet someone, it's almost as if I'm engaging in a phase 8 real evaluation. I'm looking at the client's symptoms and their responses to our work, not just at the beginning, but at the beginning of every session. I want to check in and say, hey, how was your week in relation to the symptoms we're working on? And what was it like for you after you left our session? Right? Immediately after and during the week, because I'm constantly reevaluating and assessing both macro work of how's my treatment plan going, and then when it comes time for reprocessing, the micro work of looking at that specific target. So hopefully that gives you an idea that we really need to make sure that our clients are staying stable within the window of tolerance and they're making use of the practices that we're giving them. And if they are, then it's an indication that we can move forward. If they're not, we might want to slow down the work and maybe even consider reversing the order and work on phase 2 preparation phase work before we move into phase 1. So that's what I want to talk about now. Order is not always orderly. And so the standard protocol, the 8-phase protocol, is not necessarily a one-size-fits-all order of therapeutic operation. Again, it's beautifully designed for us if our clients can tolerate the order. But when it's not, we want to be aware. We want to be aware if they're tolerating the work and make adjustments accordingly. So as I said before, if the process moves along at a steady clip and the client is able to share their goals for therapy, relay information about their past in a relatively cohesive narrative, and tolerate the emerging therapeutic relationship, that's a good indication that we can keep moving forward. But conversely, if the client is unable to even tolerate history taking without becoming dysregulated, hyperarousal, dissociative, hypoaroused, or overwhelmed, the pace needs to slow dramatically. And again, this is where I'm going to start looking at, if I'm the clinician, reversing the order and just work on phase 2 preparation, stabilization, maybe some grounding and presentification work if my client is dissociated before we begin the task of history taking. So we're going to postpone history taking and shift the focus of our work towards containment, grounding and presentification, affect tolerance, both in and outside of treatment, emotional regulation, and if appropriate, daily living. We want our clients to have some modicum of stability in their daily life and ability to function in daily life before we move through with reprocessing. And this is the art of EMDR therapy. This is not a check all the boxes and one size fits all even for each client when we're looking at this shift of postponing history taking in lieu of and focusing more on the preparation phase. We have to consider, okay, would reprocessing at this moment destabilize my client further and they can't tolerate it? Or can we move forward toward reprocessing because reprocessing the memories might actually help them with some of these elements, such as daily living and emotional regulation. So it's really something that we need to be always assessing and considering as we're moving forward in the work. And then we move to the third element here, which is readiness for reprocessing. Are they ready to move forward? And there's some ideas that we can consider, some concepts we can consider. A client isn't going to hit all of these necessarily, but they're important to take a look at. So the ability for the client to tolerate the therapeutic relationship, to self-regulate, to tolerate both positive and negative emotions, to tolerate both positive and negative physical sensations. And it isn't that these negative sensations or emotions aren't disturbing to them, but they can at least tolerate them without decompensating or having an abreaction. That they can tolerate memories, past experiences, and perceptions. They can at least name the item for a target list, say, for example, without decompensating. And that they have the ability to practice and benefit from some of those therapeutic exercises that we've taught them, such as container, calm place, and RDI. The ability to consistently engage in self-care and adequately function in daily life. And they have some modicum of social support, and that we've addressed any secondary gains or losses. Those issues have been addressed in therapy, either explicitly or that we've worked with the client to resolve any secondary gains or losses. So when considering readiness for reprocessing, we might want to look at a couple questions. These are some questions that I asked myself. Given what I know about this individual client, would reprocessing at this moment destabilize them? And if my answer is yes, or I strongly believe it to be yes, my clinical intuition, right? My treatment plan needs to flip order and focus more on stabilization and readying the client for reprocessing. But I also want to consider, given what I know, would reprocessing benefit the client by giving them relief of symptoms that they're currently experiencing that are directly related to target memory or memories? And if I believe that is the case, and maybe I'm even going to collaborate with my client in designing this treatment plan, if I believe that's the case, my treatment plan can shift toward reprocessing memories on the target list. And at the same time, I'm going to continue to assess client symptoms during and between sessions. So I'm always reevaluating. And while I'm considering, is my client ready for reprocessing, I want to say a word about countertransference. And this is sometimes comes up for newly trained EMDR therapists, and it's completely normal. If I'm considering holding off reprocessing, I have some anxiety or worry about the client's ability to remain stable and to tolerate reprocessing, I need to also consider, whom am I protecting here? Do I have a discomfort with my client's targets, or am I uncomfortable with them getting upset or feeling emotions or expressing emotions related to their targets or in session? And so you really want to make sure that your side of the street, so to speak, is clean on this one. And if it's not, that's okay. But you need to not hold off your client's work. You need to maybe turn and do your own EMDR work, or get consultation from an approved consultant or just an EMDR colleague that you respect that might help you suss out, is this client really ready? And it's me as the clinician that needs to take a look at what I'm not ready for and get that extra training, get consultation, and then again, do your own EMDR therapy. So number 4 on this list to consider in our treatment plan is symptom relief, because this is our goal, right? To provide symptom and stress relief to our clients. That's why they come to therapy. And so when we were working in the first set of this series, looking at symptom-informed target lists, you remember we worked with a client who had social anxiety, feelings of I'm not good enough, worthlessness, fear of authority figures, and a phobia of dogs. So we're going to use this example when we're looking at how to determine our treatment plan in terms of giving the client the best symptom relief. And so we had come up with a target list for their first cluster. And if you don't remember this, just take a look either at the blog on our website or on the YouTube for this first, the symptom-informed target list series. So with this, we created a target list or target cluster around feelings of worthlessness. This was related to childhood of origin stuff that went all the way through to the present, and a list of current triggers. So that's one cluster. But then we also had another cluster for this same client that dealt with dog phobias. And so we have a second cluster of past memories related to a current symptom of fear of dogs and a list of current triggers. So we have to decide, where do we begin? Do we start with the feelings of worthlessness and that cluster of past memories and current triggers, or do we start with the dog phobia and those past memories and current triggers? As a general rule, and of course there are exceptions to this, but as a general rule, we want to begin reprocessing the memories related to the most severe symptoms. Why? Because resolving those memories would most likely give the client the greatest symptom relief. So if we look at this client's example, and we're going to talk with our client about this as well, but I could hypothetically imagine that we would begin with the target list of past memories and current triggers related to the issues of self-worth, because those would resolving those past memories and current triggers would give the client greater symptom relief in more aspects of their life, both personally and professionally. And the dog phobia can wait, and we can do that secondary once we've worked out the self-esteem stuff. Conversely, a client might be really nervous about doing EMDR reprocessing. They might be stable and ready, but they themselves are a little anxious about it. We do maybe some RDI around it, but they still feel like, I just don't want to start with all this childhood of origin stuff. Can we just work on the dog phobia list first? And that might be a reasonable starting point in our treatment plan, because it's more like low-hanging fruit for the client. It doesn't deal with a lot of childhood origin stuff. It'll still help and benefit the client, probably be easier to get through and faster to get through. And they would have a strong sense of, oh, I get what this EMDR thing is, and I know I can do it well. And so again, there are no right or wrong answers to this, but we need to use our best clinical judgment. And when doing so, to think about these 4 elements that we've talked about: pace, order, readiness, and symptom relief. And so I hope this has given you some good help in working on your treatment plans. The third installment in this series will be looking at the Three Pronged Protocol, which will be looking at specifically, once you've picked a target list, a cluster to work with, how you work it within it. So please do stay in touch. We love to hear from you, and you can find us online at these various socials. Thanks so much, and we hope that you're well.